Hi. Hi, everybody. Good evening from the 18 EANS task force. So dear 18 members, dear EANS members, dear non-members, I welcome you to this webinar. Tonight, we have chosen the topic of customized spinal implants, which is, according to us, a very important topic, a very interesting topic. And we will have two great speakers tonight, and I will introduce them very shortly. We welcome you all, and please, the discussion will be all at the end of the two presentations from our speakers, and ask questions directly on the Q&A session. So just a small background why we did choose this topic for the tonight webinar. And I'd like to share with you my few slides. Here we are. So customized implants represent significant advancement in the field of spinal surgery. These are implants which are designed and manufactured to fit perfectly the anatomical and physiological needs of patients. And they seem to have some advantages on off-the-shelf implants which are available in the market. They are part of a wider concept, which is the precision medicine or personalized medicine, which is an innovative approach to develop targeted prevention strategies and therapies which are tailored to the patient's needs, genes, environments, and lifestyle. Since the first description by Paul Durso, where he actually developed stereolithographic plastic models of the spine, and he used it for surgical planning, patient education, and surgical navigation. There have been great strides in the field of customized implants. And nowadays, we do have available many of them on the market. And I just try to show some few applications in the field of spinal surgery. For example, nowadays, we do have available 3D printed customized cages for interbody fusion or for reconstruction after corporectomies. Like you can see in these images, and I think that our speaker, Professor Spetzger, will talk about interbody fusion cages. We do also have available reconstruction cages for very peculiar regions like the craniocervical junction, and I think that Alessandro Gasparini will talk about it. Artificial intelligence also helps in developing customized implants like personalized rods from a software where nowadays we can actually plan the surgery and develop and print titanium or chrome cobalt, whatever material rod to facilitate the surgery. We can also print in 3D printers tubes or dedicated tubes for MIS solutions according to the depth of the surgical field. We can also use some templates which helps to introduce and inserting pedicle screws according to the posterior anatomy of the vertebrae. Which are the advantages according to some specialists and authors, on using customized implants compared to the off-the-shelf implants. First, the easier implantation, because if you are fully dedicated, fully designed to cover and fit the anatomy, that will be minimal end plates preparation, for example, for the interbody or vertebrectomy cages. And so the implantation will be faster and easier. There will be an improved device bone load distribution. We know that fusion is highly impacted by this interface between the device and the bone itself, providing primary stability of the implants and ideally improving the outcomes. We can also enhance, for example, osseointegration. Again, if you go back to the load distribution, you see the difference between a pig cage on the left and a customized cage on the right. You see that there is a better interface between the implanted bone on the right side. Again, osseointegration, enhanced integration has been demonstrated, especially for the 3D printed cages with this very dense trabecula of the cages, which might improve osseointegration inside the cage and around the cage and to the bone. And all these features will ideally minimize operating time and improved outcome. And last but not least, we can also probably operate much easier today some specific region of the spine, because we do have available customized implants, like in the case of this very nice craniovertebral reconstruction. But nevertheless, there are some disadvantages. Most of the papers, literature, evidence is low quality, is case series, is technical case reports. So there is a lack of quality data, unfortunately. There is research challenges. There is, of course, a need for skilled laboratory or research groups developing and printing this kind of implants. There is time needed for an increased preoperative planning, because you need to send the CT scan and MRI to the manufacturer to obtain the final implant. And there is, of course, a reduced intraoperative flexibility. If you print a personalized rod, you must be perfect in releasing the spine and bringing the spine to the rod, more than bringing the rod into the head of the screws. Sometimes multiple implants need to be produced per case in case there is a non-perfect fit of the implants to the surgical field. And of course, last but not least, there is, of course, challenging regulatory environment, which is not clear at all about these customized implants, which takes sometimes many weeks to be obtained because of the administration issues in the hospitals. So again, tonight, I do welcome to this webinar, and it is my pleasure to introduce the first speaker, Professor Uwe Spetzger, who is Chief of Neurosurgery in the Karlsruhe Hospital, and is a active member of the Karlsruhe Institute of Technology. The second speaker will be Alessandro Gasbarini, who is Director for Spine Unit for Oncological and Degenerative Diseases at the Rizzoli Hospital in Bologna. So thanks again for being with us, and I give the podium to Uwe Spetzger. Please, Uwe.
Enrico, thank you. Can you hear me? Okay, perfect. You've mentioned the main topics, and I just want to add our experience. It was in 2015. We get this three-dimensional printed titanium cage for cervical fusion. It was a real pilot project, and but it, as you mentioned, still is on the basis of a pilot project because it never get the drive due to several reasons to be in the clinical routine. I will share with you our experience with this production, manufacturing, surgical planning, and the pro and cons of those individualized titanium cages for cervical fusion. As mentioned, we published it. It was a case report. As you also mentioned, it's not a big series. It was a case report. Meanwhile, we have done 3 other cases, but it's a lot of administrative problems and a lot of fiddling around to get these cages produced. I will show you and share with you problems and the manufacturing. As you all know, 3D printing is here to stay. Everything is possible. Everything could be printed. Probably can use those to solve the problems in the Ukraine war to print these weapons, but everything is possible. As you mentioned, I'm part and member of the Karlsruhe Institute of Technology, the KIT. It's the biggest institute for research in Germany, and it combines technical university and with a scientific purpose. And I'm a member of the Faculty of Computer Science, Institute of Anthropomatics and Robotics. And out of this, also the idea of 3D printing was born. The idea of an optimal, let me focus on cervical cage, should be easy to produce, low cost, as you all mentioned, is the main topic, especially after Corona, must be safe. It must be easy to implant with our usual microsurgical surgical techniques. Nothing special. It should be a straightforward strategy, straightforward surgery. And as overall goal is, it must be perfectly fitting to the load-bearing surface. And for sure, we all wish that we can create perfect outcome with these optimal customized cervical cages. And especially, we have to respect the patient's anatomy, and the aim and goal is to correct the spinal pathology with the insertion and insertion of those cages. Therefore, customized, individually shaped implants will be a solution, as you mentioned, in personalized and high-end modern medicine. The overall principle of those implants is to adapt the implant to the patient's anatomy. This is the overall philosophy. At the moment, we are on the stage not adapting the anatomy to the available cage. This is our routine procedure in our daily routine, inserting a cervical cage. And I think adapt the implant to the patient's anatomy sounds a little bit more familiar and sounds a little bit more logical. Therefore, as I mentioned, this will be in the future the philosophy of personalized medicine. Therefore, we thought 7 years or 8 years ago, let's design and build such a patient-specific cervical implant and go for it. And this was the result of our first cages. And you see, it is not a typical model of a typical design of a cervical cage. It looks like a cervical cage, but if you look to the bumps and bruises here, it is not like usual. You're all familiar in spinal surgery, implanting a P cage or a carbon cage or even a titanium cage. You go for it with a template, insert the cage, impact it, and normally it fits quite adequately, as is here seen in a 6 millimeter height cervical disc. You discraft it and bring it in, like usual. And if you measure your anatomical conditions, you not always have those straight plans. You have bumps in it, you have spurs in it, and you have those irregular disc spaces, as I shown you in the final implant just a few seconds ago. Therefore, I think in highly individual anatomical conditions, who are not typically plain surfaces, this will be an adequate indication for those 3D printed implants. Measure here 5 millimeters. How much is it? 4 or even less. During my education and training, I was familiar bringing in these PMMA implants. And this is part of the philosophy, because you adapt really your implant, it's malleable, and you bring it in and it shaped to the patient's anatomy. You have a lot of other problems, heat producing and so on, and embolisms, but the philosophy adapting the patient's anatomy to the implant is perfectly done in those PMMA implants. As you all know, specific here in certain artificial disc prostheses, it looks not so nice. You have straight footprints, and the patient's anatomy has to adapt to those implants. And I think this is the wrong way. It will be center a little bit, it will be come down a little bit, and it will fit all along. But is it really nice to do surgeries and adapt the anatomy to the implant? I think no. Therefore, the accurate fitting is an essential point, and it could be optimized, definitively. You can adequately create the adequate height, create the adequate dimension, shape. You will, as Enrico mentioned, create the optimal contact surface and enlarge your load-bearing zone to those implants who are specifically designed for the patient's surface. And the steps for production of those customized cages is you need adequately high-end CT data. You need a computer-assisted simulation like a virtual spine surgery. And for sure, you need the 3D modeling of the cage and the design, and then the pre-planning and the pre-positioning in a good computer model, especially to try to correct the anatomical condition and a little bit reduce the kyphotic situation. And the last step will be the 3D printing of those designed cages in a selective laser melting technology. As usual, the cages, the normal cages, are produced in the same manner. And we do this project together with a company AIT and with a software company. Meanwhile, it's on the stock market. 3D Systems. They create a lot of 3D software and image solutions. And we do this virtual surgery. We planned the exact position of the spine. We planned the exact resection of the osteophytes. We planned what should be removed during the surgery, what we create, the decompression of the spinal canal, the decompression of the spurs in front of the spine. All this was virtually simulated with the 3D software. We do it in a many transatlantic video demonstrations, and plan this on a screen, plan the implant of the customized cages, and where sufficient with this situation after repositioning the spine and so on. This was our final model of the cage. It's a 3D model. We also inserted it virtually, look at the adequate decompression, look at the adequate reposition of the spine. You see it here, the back side and the front side, and it's based on a typical cage, but it's really highly individually shaped, the surface, and represents exactly the anatomical conditions of these patients. The cage was then 3D printed. You see the model and you see the definitive ready printed cage. And this looks as it is very easy to implant in the anatomical condition. It was, like I mentioned, done in a selective laser melting technology. A laser beam go over the surface and melts this titanium powder with a high temperature procedure. And it's a programmed CD CAD file, and this will be the result, as I mentioned, and repeating this spot by spot, and you create layer by layer these cages as it was done in a usual commercially available cage. And our first surgical procedure was done 2015, as I mentioned, and we do this in the VR surgery simulation and planning with a 3D system. The perfect and press-fit implantation was adequately done. It was an easy implantation. You see, it fits exactly to the dimensioned surface, and it finds a way inside, like a key in a lock, and it was quite easy. You do not need any navigation. You just remove the cartilage of the end plates and respect the bone, and then the cage, the pre-designed cages, exactly fits in. And this is a postoperative follow-up. You see the X-ray. You see it is exactly positioned in the same manner as it is planned in the virtual situation, and highly magnified. You see that it is exactly fits to the surface. There, the osteophytes were a little bit overtreated, but to decompress adequately, the spinal canal was necessary. But you see that it's a perfect fit in the end plates, upper and lower vertebral body. Therefore, we were enthusiastic and thought the future perspective will be those individual cages. But there are some pros, and it shows many pros, but I always show you some cons, because the time management to create these cages, especially to adequately shape the adequate design of the cage, needs a high time management. We have to optimize our workflow. As Enrico mentioned, probably AI will be helpful in the future to reduce these enormous time effort for the production and the VR surgery. I think semi-automatic planning, we tried this at the KIT in many cases, is not exact enough. You have to do this not semi-automatically, you have to do it as a surgeon by yourself and create the adequate shape of the cage. And probably it will be a future perspective that the improvement of the modeling will be semi-automatic or ideally automatically. And I think we have only rare indications for those spine cages, for the cervical cages, because especially in highly atypical anatomical condition, it's worth to do this cumbersome pre-planning and production of the cases. And as also Enrico mentioned, we have a lack of scientific evaluation. We have no real long-term follow-up. We have this in our 3 cases, where I have a perfect long-term outcome, but it's not comparable to huge series in typical commercially available cages. And the next topic is our insurance companies will not reimburse this. The cost of the implant, if we try to estimate the cost of this first implant, it was many thousand euro because of the transfer of data, because of the virtual surgery, and because of the really cumbersome process of producing these cages. No reimbursement for those cases. This will be the definitive problem for the insurance company or for our hospitals. Therefore, further topics and the topics of discussion later on will be, it will be an adequate and attractive concept of personalized medicine, but 2015, we are far ahead of this, and it will come probably in the next years. And if you closely look to the effort-benefit ratio, this is a lot of effort, but the benefit is not adequately scientifically proven. It is nice to see, and you see the load-bearing zone is very nice, and the fitting is very nice, but it's really an effort who is payable. And these are the questions. Are these really additional costs? And it will cost a little bit more than a routine cage. Is it justified? This will be the major or crucial topic for our insurance companies and also for our hospitals. And I think this will reduce the enthusiasm, because I think it's all necessary in highly selected indications, in very raw and very bumpy end plate situations. I think then it is justified to go this way and present and print such a very cumbersome and not so easy producible individual cage. I thank you for your attention and I'm open for discussions.
Thanks a lot, Uwe, for this very nice presentation, and we will keep the discussion at the end of the webinar after the second presentation. So welcome to Alessandro Gasbarini, who should be around. Alessandro, can you hear us? I see you.
Yes, yes.
Hi.
I listen very
Ciao.
well.
Ciao.
Hello, hello,
Welcome.
everybody. Sorry,
And
I arrived a little bit in delay, but now I'm ready. And
great. Thanks for being with us. And if you can
my...
share your screen with us.
Yes. Condividi documento 1, questo. Apri preferenze. I have problems with quando faccio condividi, dice consenti a Zoom di condividere il tuo schermo. Apri preferenze di sistema, sicurezza e privacy per garantire l'accesso. Quindi sicurezza e privacy.
Dipende dall'applicazione Zoom che c'è.
Adesso vedo sicurezza e privacy, eccolo qua. E devo consentire.
We can make a small discussion if you have technical problems. We can discuss. There are already some questions in the question and answer.
Yes, it's better.
Okay, I do have a question to Uwe. Uwe, can you are on mute? Can you unmute yourself?
Now, yeah.
Thank you. Because you were mentioning, I mean, the timing, no, and to limit these personalized cages to specific cases. So I guess that these cases could wait for the manufacturing of the cage and for all the, do you say, the administrative work for insurances, and it takes some probably days or weeks. Which was your experience for that?
It was the printing of the cage was very easy. It is some hours just for the printing, for the laser melting process. But the planning is the main topic. The planning is you need, in the beginning, we need hours. For our third cage, we have probably 1 hour for the planning, for the virtual surgery, remove the osteophytes in the 3D program, and bring in the adequate fit of the cage. But there will be a slight problem during the surgery. If you do it in the same way as you are familiar with, drilling the end plate, then you will destroy the adequate shape of the end plate. Therefore, you have to be carefully reduced with a spoon, with a sharp spoon, or with the dissector, the cartilage end plates, and respect the bone. It's a little bit different surgical strategy. Otherwise, you will flatten the situation, and then the typical lock-in of the pre-shaped cage will not adequately be so easy. Therefore, be careful during the surgery, and I think in especially very highly bumpy situations and atypical valley and mountain end plates, then the cage will fit in perfectly. I think these are the 3 or 4 crucial points.
Thanks a lot. Now I do see that Alessandro is on the starting grids, and please, Alessandro.
Okay, thank you very much for the invitation. I present myself. I'm Alessandro Gasbarini. I'm working at Rizzoli Institute in Bologna, and we made all the pathology of the spine, of the hardware of the spine, not the software, but every pathology. But our skill is on oncologic patient, and our topic is when we use 3D printed prosthesis, and so before we try to find something as than the normal prosthesis, because when we remove a tumor, if the tumor is the red of the eggs, usually it's possible to remove by debulking, by curettage or en bloc. And when we remove en bloc, we need to substitute the removal piece with something. And so what is the best prosthesis? I don't know if there is an answer to this question, but in the time we try to use bone, we have a bone bank. We try to use cages, arms cage or pyramid or cage with bone. We substitute sometimes with the vertebral body from a bone bank. For a long period, we use these carbon fiber stackable cages with very good result, bone formation inside. Not very good result with expandable cages. That is very good in when we remove eggshell, the tumor, but when you remove en bloc, is not very stable and is not possible to connect with the posterior instrumentation, and so we are not deal. And so we try to find something else. This is 3D printed prosthesis. The ideal implant is a quick reconstruction, a connection with the posterior instrumentation to perform a 360 degrees instrumentation. Is important that there is an osteointegration and needed to be radiolucency to avoid scattering during radiation therapy if he needed. And this is our prosthesis. Is externally is the shell like cortical bone. Internally is like cancellous bone. There is a polyaxial connector to connect with the posterior element, and just 10% of the volume is titanium. The other part of the vertebral body is air. And so this is our objective to, we try to allow the growth of the bone just for 2-3 centimeters enough to guarantee the good result of biological of the prosthesis. When arrive a patient, we have a lot of material. We have MRI, we have CT scan, we have X-ray, and so it's easy to send to our engineer to describe what is our resection, and after to perform a perfect reconstruction with the connection with the posterior elements. And the resection is very fast, and the reconstruction is faster, because we resect the vertebral body with Tomita or Gigli saw, and so the surface is perfect. We study our casuistic with there was some primitive tumors. The most part of the cases is a benign grade 3 according to Anakin stage, or malignant, primary malignant tumor 1, 2, and AB, intra and extra compartmental. And sometimes in very selected cases in solitary bone metastasis, when the oncologist don't have other therapy for that location, and usually in solitary lesion, not treated in other method. Our casuistic is 24 patient, and we exclude the debulking, just en bloc. This is a case of an osteosarcoma, and in the 12 cases was primary bone tumors, in 8 cases solitary metastasis. And this is one case of metastasis. This is the MRI before surgery, the PET scan that shows just this lesion without any response to radiation therapy. And so, according to oncologists, we decide to remove and block. In this case, we perform a double approach before anterior approach to release the aorta and the cava. And after, through posterior approach, we remove the vertebral body and we put this prosthesis. The advantage to have a very precise reconstruction is important because it's very fast, the reconstruction, and is very solid because it's linked to the posterior elements. This is before and after surgery. This is the axial view and the coronal view. And so there is an immediate, very stable reconstruction. We started this 20 patient in 4 cases, just 1 vertebral body, in 7 cases, 1.5, in 5 cases, 2 vertebral body, half above and 1 half below, and the vertebra in the middle. And in 2 cases, more than 3 vertebral body, and in other cases, sacroiliac junction. We had some problems with some complication, and there is no migration, no breakages, but 7 distal screw loosening. Most of part of the cases, as in this case, is asymptomatic, and in 2 cases we have a distal junctional kyphosis, and this happens when we stop in the vertebral plate and plate. The best is to put against the cancellous bone. Is very stable and is less force on the plate. This is one case that we solve with revision, and we went to sacroiliac connection. We have just 1 proximal junctional kyphosis, and we revise. In this case, we have a recurrence of an osteosarcoma, was previously treated elsewhere, and we resect with the pathologist said wide margin, but we know that it's impossible to have a wide margin in revision surgery, and so there was a recurrence. But and so we decided to treat again, resecting all the prosthesis after 1 year. And with this section was possible to see how much bone growth inside the trabecular cancellous synthetic prosthesis, with very good growth of bone inside this trabecula. And this is an histological slice that you can appreciate the growth of bone inside the titanium. And this is a slice. You can see how much titanium there is inside, very low. There is a lot of air inside. And this is very important if you need to perform radiation therapy after surgery. But to substitute 1 cylinder of bone, like a vertebral body, is not the advantage, in my opinion, of this 3D printed prosthesis. I think the really advantage is when there is not on the market something to substitute one piece of bone. In this case, we designed this prosthesis that have a saddle to bring Atlantis, and one body to substitute C2 dent, and to attach in C3 with one plate design with the prosthesis with 2 screws, and was very easy, the reconstruction in this case after resection, and the movement of the patient was really good in a short time. After 1 month, this was odontoiatric, was possible to work without any other support. And so this is a complex okay. This is a complex reconstruction, and another complex reconstruction when we have to substitute the sacroiliac joint. There is no prosthesis in the market to substitute this particular joint. This is a case of ovarian metastasis. It's very rare tumor, but is with very good prognosis, and so we decided to substitute the tumor with a 3D printed prosthesis. This is another chondrosarcoma treated, is a very huge sarcoma that needed to have a wide margin, and so to remove one piece of L5. This is the design before from the engineer before the prosthesis. Is important to show that it's not important to reconstruct exactly what there is in nature, but the important is to avoid to follow the stress line of the weight bearing. This is one segment is a posterior approach. With the navigation, it's possible to see where the screw go inside the pelvis and inside the other side of the sacrum. And this is the CT after reconstruction. If there is no reconstruction in this patient, all the spine go in a big deformity with a big kyphoscoliosis, and it's difficult to walk without a reconstruction. When you want to perform a complete resection of the sacrum, it's possible to walk without the sacrum, but have to be bilaterally. If there is a resection of just one side, it's impossible. As in this patient, this is a high-grade chondrosarcoma, always in the sacroiliac joint. We perform the anterior approach with the robot with Da Vinci to release the vessel and the rectum from the anterior part. This is the video of the resection of the gluteal artery. After isolation of the iliac artery and vein, we pass anterior to the sacrum and posterior to the vessel, this mesh to separate all the vascular bundle. And after we go posteriorly, but before this step, we talk with the patient that arrived from Israel, from Tel Aviv, and he is a young boy. He's 30 years old. For me, he's young, And I explained to him that it is important to resect all the nerve to have a wide margin. But the patient refused this. And so we decided to remove not en bloc, but intentional resection of intentional margin, intralesional margin. Now with bone scalpel, we resect and we try to save all the roots. Have you seen here? There is all the roots preserved, and after our prosthesis is not anymore correct for this because it's impossible to put these big prostheses with the roots in the middle, and so we decide to customize one customized vertebral reconstruction, and we resect in 3 pieces. And after we put the prosthesis, and you can see in the posterior part of the prosthesis, there is a vascularized fibula to have a biological reconstruction, more vascularized in this side. This is the reconstruction. Fortunately, the patient, after 20 days, was possible to move with some problems, but and we send this to the pathologist, all the spacement, and unfortunately we decide not to resect en bloc, but to resect by 2 pieces, saving the roots, because it was not an high-grade chondrosarcoma, but was chondromyxoid fibroma. The first diagnosis was done in Israel, and obviously was not well done. So this was a chondromyxoid fibroma, and so the surgery for these tumors is intralesional removal. It's important to know that the titanium and the bone are different, and so when you need to reconstruct one piece of bone, it's not important to reconstruct exactly, to put something exactly the same that you remove. But as in other situation, like in a breast cancer, when ladies want to have a normal breast, in bone, it's not important to reconstruct the same, but to follow the burying line. And so sometimes it's better to have less metal to allow the detection of local recurrences, or to allow the radiation therapy after surgery, avoiding the scattering effect. And so, in my opinion, the take-home messages from this presentation is the 3D printing seems to be safe and effective, is a little bit more expensive than normal prosthesis that you find in the market, but is very fast, the reconstruction, and it's possible to cover with the silver-coated prosthesis when there is a risk of infection, and sometimes in radiated patients this is very common. In complex reconstruction is sometimes there is the only option that you have, because bone bank sometimes is not enough in a young young people, sometimes bone bank have not the size, the correct size. The bone growth might be promoted by surface details, and so it's important that the engineers know how much spaces have to be between the titanium. I think in the future there is not just a titanium, but there is some print machine that print carbon fiber too. And so I think in the future we can use other material. Why not the bone? The important things that you have to respect very well the staging and the planning before surgery is mandatory and is important to do before surgery, and is important because all is step by step and with the immediate availability makes the reconstruction very quick. And now up to now we have titanium. Titanium is a very good material, but sometimes is not the best for our reconstruction. And so we are waiting for some other more biological reconstruction and material. Thank you.
Thanks,
Bologna.
Sandro, for also this very nice view of Bologna. And I give the word to Nicola Gabrowski for the discussion and the closure of the webinar.
Thank you very much, Enrico. Indeed, we advanced a little bit too much in time, but I first of all would like to thanks to our presenters, to our speakers for these outstanding presentations and cases and technological advancement. I had one question for them, and I would like if they both, one after the other, answer. We know that the 3D printing has been a well-known technology since the 80s, but it was extremely expensive. And of course, we didn't have this computing power. After I saw these presentations that have been quite different, but looking at the same direction, I would like to ask you, what do you think the future of 3D printing will be in spinal surgery? Because we started with a lot of enthusiasm, but I think that we are narrowing little by little the field of application of these implants, and probably they will remain important only for very complex, sophisticated cases, as we saw in the second presentation. So what do you think will be the future of 3D printing? Juven?
Yeah, you mentioned it, Nicola, because I think we are starting enthusiastically, and but if we closely cut down the real indications for these 3D printed implants, we will end up in very selective cases, and probably AI and probably some administrative easements will get it a little bit more common on the market. I think administrative problems are the main problem. Also, medical legal problems, if you have a failure and you have a self-printed cage or self-printed material. I'm married with a lawyer, therefore I know that medical legal problems could pop up not 5 or 6 weeks after the surgery. They will pop up after many years, and this could be a hindering for the more evolution and more evolving of 3D printing. And it was also mentioned that I think future materials will bring a new drive into this project.
Thank you.
There is two kinds of 3D printed prosthesis. There is one that is normal cages. They produce the company with the 3D printed fashion, and this is important because sometimes you can design very well something that is impossible to design with the same without 3D printed. Like I remember tantalum that is very fast in growth, because there is something very similar to the bone. And with the 3D printed, you can design the perfect solution for the one rapid reconstruction and the ingrowth of bone. But and after this is one. The other possibility is to perform something tailor-made on the patient. This is different. Tailor-made on the patient, I think, could be a future, because you can decide the material, you can decide the size, you can decide the timing, and now in Rizzoli Institute we have one room with 3 printed machine with the engineer inside, and so it's possible to decide according to the engineer what is the best solution for this patient. And so and why not tomorrow is possible to produce the same with bone, not with titanium. And so I think that is important that there is a normal material for the reconstruction, normal the company, but you need something more. And is, I know there is 2 problems. One is it's expensive, but it's expensive because there is not a lot of people that use this method, because if not, it's less expensive in the future. The other is from medical legal point of view, because you are the surgeon and you are responsible of the with the engineer if something break. If the prosthesis break, there is not one company to that go to the judge, to the lawyer, but it is you, because you have the responsibility of the implant. And so it's very important. For me, it's easy, because in oncologic patient that have no other solution, but in patient with degenerative or deformity, I think at the moment they can't accept this huge responsibility.
Thank you very much, Alessandro. Well, we are running out of time. The topic is extremely interesting, and of course, these have been very important messages for all of us. Despite though, I hope that despite all these challenges, I hope that in the field of customized implants, there will be a lot to be seen in the near future. We have an enormous advancement in the different materials that can be applied in the AI application, so this process can probably someday become very fast and really applicable for a broad spectrum of pathologies. Who knows? We shall see. We shall follow this. I would like to thank some of you for this participation, and I hope to see you to the next webinar that will be announced very soon, next webinar of ETIN. Have a nice evening, and see you very soon. Thank you very much.
Bye bye.
Ciao. Ciao. Ciao.
Ciao. Grazie.